disc space is there, and the osteophytes are getting also formed there. So this is the area which we want to do the Olif on. We position the patient, the left side is always up. We approach from the left side because that is where the Olif corridor is. Confirm on the AP and the lateral that you are getting a good picture. So for 2 level you can do 2 incisions, but usually a single incision is good enough. So we mark the vertebral body on the skin, and then a small incision. This is the cranial end of the patient, this is the caudal. This is a disc space which has been marked, the vertebral body. We don't need to regularly mark it, the disc space is enough. This is for demonstration purpose. A small incision around 8 mm skin incision and dissection of the fascia. So we just do a finger dissection like we do it for the ACDF. And this is the fascia or the external oblique. So as orthos, we are reluctant to operate on the abdomen, but it's like doing the ACDF for the cervical. And the muscles are then split along the directions of the fiber. So as you all know, 3 layers of muscle just split in according to their direction of the fibers. Internal oblique, external oblique, and the transversus abdominis all again split. In that you can see the direction of the fibers and just split it with a blunt artery or a finger and just expand the corridor till you see the peritoneum. And then we use hand-end retractors for the initial part of the approach. You can use a thin Devers retractor or a long Langenbach. So now the transversus abdominis is split, finger dissection of the fascia transversalis. And then the peritoneum and the fat is pushed anteriorly. So this is how you do it. You just angle your fingers backward and feel the transverse process, and then start coming anteriorly onto the psoas. And then use the handheld retractors, and you can put the first guide wire or the first dilator through that and confirm it under C-arm. The psoas is identified, and just at the anterior border of the psoas, you will find the bare area, and you can just mobilize a little bit of psoas posteriorly also. And then, like for ACDF, for the cervical, you are directly onto the bone or the disc. See, this is the Olif corridor. Just with a piece of gauze or a Kittner dissector, which is the laparoscopy people use, you can use that. The disc is identified. Small amount of bleeding from the margins can be controlled with a bipolar. So usually you need a little longer bipolar for that. And then make a discectomy cut. And usually you can do a quick discectomy, much more than the TLIF. And these are the channels in the retractor in which you can pass a pin and anchor it to the vertebral body. And remember, if you are doing L4, L5, don't put the pin in the L5 vertebral body because you may have the vein there. So one pin is also good enough to anchor the retractor. Just do a discectomy like you do it usually. So most important is to remember the orthogonal maneuver, because we are approaching the spine in an oblique way, and we have this retractor which is opening up on one side. So every time we put in the instruments, we need to do the orthogonal maneuver and come perpendicular to the spine. This is the first dilator. And then confirm it under CR. And then finally, the retractor which we want is placed. the Siam image. You can see that the guide wire is in the proper disc space. And then just open it up. So that was just the initial small discectomy to anchor the first dilator. Once everything is put in place, then we do the, and this is the orthogonal maneuver. We enter obliquely and then make the instruments perpendicular to the spine. So remember to orient the opening of the retractor in this direction, like this. So all the instruments, they are introduced obliquely and then made perpendicular. So like this. So you can see they are inserted obliquely and then made perpendicular. So you can see here it is being inserted obliquely, hammered in a little bit so that it just anchors into the disc space, and then just push it into the orthogonal plane perpendicular to the spine, like this. You can see it. So through this space in the retractor, then we go perpendicular to the spine. So this space allows us to do that. So serial trials are there, shavers, everything is there, same like in the T-Lip, but again, but bigger size for the Olif. So this is a retractor pin which is holding the blade so that every time we hammer it doesn't dislodge. And you can see here, just on the superior part, the pin has been placed. And then the orthogonal maneuver, you can see the trial. And then the cage with the bone graft. You can do a small incision and take the ASIS bone graft, or there are graft replacements also now. So this is a Siam image. You can see how big a cage has been placed. So this allows a good force of correction and a good amount of release, which we can do anteriorly, which is not possible in posterior approaches. So this is the height of the cage. You can see a big cage has been introduced. And then as we remove the retractor again, everything just falls back. And always remember to close the muscles in the fibers in the direction in which they have been split to prevent an incisional hernia. You can see all this falls back. And then standard posterior MIS fixation, you may do it in the lateral position if you are an expert, or you may turn the patient and do it posteriorly. So this is the final picture. You can see how much gain in the height, and this is the MRI, and you can see post-operatively a big cage has been put there. So this is all about the Olif video. So if there are any questions?
Olif I want to know what are the precautions he follows during the operation to accidental migration of instruments in the spinal canal.
So put the instruments and the Siam guidance, and the orthogonal maneuver, like I said. So always ensure that the patient is in dead lateral position before you start. So every time if the patient is placed obliquely tilting, then you don't know where is the exact lateral, right? So once you place the patient, put the Siam in the proper lateral position and take the shot. Now if you see that the patient is a little oblique, now start tilting the table till the patient is perpendicular to the floor. Every time now I have to go perpendicular to the floor.
That is assuming the orientation of the patient.
Yeah. And so it has to be in the dead lateral. Like you do a THR, for example.
Another question of me, did you ever experience any disc bulge after putting cases from an Olif approach causing stenosis of the...
No, so for my practice, it is mostly for a collapse disc and for a deformity correction, where the disc bulge is not there. Idea is to jack up the disc. And you can do a good enough discectomy. That is there.